All right. Hello, we can get started. We have a forum and everybody's already so quiet. So welcome to the first grand rounds of the year. It's my pleasure to introduce the speakers today. So Renelle Lim will be our first speaker. She's Assistant Professor of Ophthalmology and Visual Science, and she's the Director of the Smilo Cancer Hospital's Ocular Oncology Program. She received her MD from the State University of New York Downstate Medical School, and also trained under Carol Shields at Wills Eye Hospital in Philadelphia. And she completed 2 fellowships, one in oculoplastic surgery and in ocular oncology. And she's the director of the Ocular Oncology Program and sees patients with common and rare malignancies of the eyes, and will speak to us today about ophthalmic immune-related adverse events. So welcome, Dr. Lim.
Thank you so much for the kind introduction. My name is Renelle Lim, and today I'll talk to you about the ophthalmic immune-related adverse events and share our experience. I have no financial disclosures, although a few of my co-authors are consultants. Today we'll discuss the mechanism of action of checkpoint inhibitors and detail a few cases. We can all agree that the relationship between the immune system and cancer is complex. With the realization that cancer finds ways to escape detection by the immune system, trends in treatment have focused on methods to interrupt cancer tolerance and reactivate the immune system against tumor antigens. Target recognition by T cells is a 2-step process. The first is an interaction between the T cell receptor and the MHC complex, or major histocompatibility complex, displayed by tumor cells or antigen-presenting cells. The second event is a co-regulatory signal that determines whether the T cell becomes activated or downregulated. And the second event will be illustrated here. You can think of CTLA-4, a receptor on the surface of activated T cells, as one of the brakes of the immune system because it functions to downregulate the T cells to help prevent autoimmunity and inflammation. When the interaction of B7 and CTLA-4 takes place, it's like stepping on the brakes, inhibiting the T cell. T cells also express another receptor called CD28, which is constitutively expressed and serves an opposing function to CTLA-4, triggering T cell activation. When CD28 binds to B7, it's like stepping on the gas pedal, and the T cell remains active to go kill cancer. CTLA-4 competes with CD28 for B7 binding, but CTLA-4 has a much higher affinity. To kill cancer cells, the cytotoxic T cell should remain active. So how do we keep the T cell active? By preventing the binding of CTLA-4 and B7 altogether. In 2011, the FDA approved ipilimumab, a monoclonal antibody for treatment of advanced metastatic cutaneous melanoma. It's been 9 years since approval of ipilimumab. Anti-PD-1 and PD-L1 were later approved by the FDA based on successful large randomized controlled clinical trials. Now, immunotherapy is considered one of the pillars of cancer therapy. Prior to the introduction of immunotherapy, the 10-year survival rate for metastatic melanoma was less than 10%. Survival rates for advanced stage 3 or 4 unresectable metastatic cutaneous melanoma are even better when combination therapy is employed. The 5-year data was recently published, demonstrating that the overall survival of advanced metastatic melanoma was 52% in the combination group of nivolumab and ipilimumab. There are currently 7 FDA-approved immune checkpoint inhibitors. And the indication for use of immune checkpoint inhibitors are continually growing to not only involve unresectable advanced metastatic cutaneous melanoma, but squamous cell carcinoma of the head and neck, Merkel cell carcinoma, hepatocellular carcinoma, renal cell carcinoma, cervical cancer, and the list continues. We recently published our experience with immunotherapy and the ophthalmic immune-related adverse events. Because the use of immunotherapy continues to grow, the adverse events will expand. And it's important to be mindful that there are ophthalmic immune-related adverse events. We reviewed the charts of almost 1,500 patients, and 15 of them, or 1%, developed an ophthalmic immune-related adverse event. Most patients were treated with combination therapy, ipilimumab and nivolumab. The most common ophthalmic immune-related adverse event was uveitis. Interestingly, all patients who had ophthalmic immune-related adverse events also had concomitant systemic immune-related adverse events, such as colitis, dermatitis, arthritis, hepatitis, hypophysitis, and the list goes on. Now let's discuss a few unique cases. This is a 75-year-old man with a history of left foot melanoma who developed widespread metastasis. He was treated with 2 cycles of Ipi and Nivo and complained of seeing distorted images. Anterior segment examination showed an irregular pupil. And you can see a little bit of scarring. And this is what we call posterior synechiae, where the iris is adherent to the anterior lens capsule. This patient was managed with topical corticosteroids, topical prednisone, and after 1 month, you see release of the posterior synechiae, and he now has a round pupil. So I mentioned that uveitis was the most common ophthalmic immune-related adverse event, and I'd like to take a minute to just talk about what uveitis is. It's simply inflammation of the uvea, and the uvea consists of the iris, the ciliary body, and the choroid. Uveitis can manifest in many different ways. Patients can present with debris on the back of the cornea, the corneal endothelium, and we call this chorotic precipitates. Patients can have cells in the anterior chamber. Usually it should be white and quiet. Usually it should be quiet, but when cells are present, we know there's some underlying inflammation, or have posterior synechiae, and that's anterior uveitis. But uveitis can affect the back of the eye more, and we call that posterior uveitis or choroiditis. And you can see inflammation affecting the choroid and sometimes the retinal vasculature. Here's another case, a 57-year-old woman with a history of choroidal melanoma, and you see a pigmented lesion affecting the choroid. She was treated with plaque brachytherapy, and you see very nice regression of the pigmented lesion. However, later she developed liver metastasis. She was treated with ipilimumab and nivolumab and received just 1 cycle. She then developed a rash, and 2 weeks later she presented with left upper eyelid ptosis and diplopia. A workup was performed, and she had elevated CK levels, myositis, elevated troponins, myocarditis, and she had acetylcholine receptor antibodies, and she was diagnosed with myasthenia gravis, myositis, and myocarditis. She was hospitalized and treated with intravenous corticosteroids, immunoglobulins, and pyridostigmine, and she had complete resolution of her ophthalmic symptoms at 6 months. However, she did have progression of disease and later received radioembolization for worsening liver metastasis. This is a case report, and I thought this was interesting because it's very similar to our patient. And the authors described an 80-year-old man with a history of cutaneous melanoma metastatic to lymph nodes who developed fatigue, shortness of breath, weakness after 2 weeks after starting nivolumab. The authors obtained a baseline acetylcholine receptor antibody level, and this patient had low levels of acetylcholine receptor antibodies. However, after treatment with nivolumab, we can see a spike in the acetylcholine receptor antibodies. And after immunoglobulin, you see the acetylcholine receptor antibody level decrease. And the same was true for the CK levels. The patient had a skeletal muscle biopsy. A T-cell receptor analysis using next-generation sequencing identified infiltration of clonally expanded T cell populations in skeletal muscle after treatment with nivolumab. And these high numbers of T cells found in the skeletal muscle biopsy suggest a strong T cell immune response against muscular cells. Here's another case. A 43-year-old woman with a history of metastatic cutaneous melanoma who received 3 cycles of Ipi and Nivo. She complained of blurry vision. Fundoscopic examination showed choroiditis, and you can see the areas of inflammation affecting the choroid. She was treated with systemic corticosteroids with improvement in her visual acuity, and she achieved 20/20 vision in both eyes. And she had a complete response to treatment and is now followed every 6 months. Here's another case, a 54-year-old woman with a history of anal melanoma with brain metastasis who was treated with combination therapy, who also complained of blurry vision. The visual acuity was 20/70 in both eyes. And the photos at the top, this is called optical coherence tomography, and this is our version of a CT scan of the eye. And it essentially scans the retinal layers, and you can see fluid deep to the retina. This patient was treated with systemic corticosteroids with improvement in her visual acuity to 20/25 in both eyes. However, she had progression of her metastatic disease and is now deceased. This is another interesting case of a 61-year-old woman with a history of metastatic cutaneous melanoma who complained of blurry vision, especially of the left eye. Fundoscopic examination showed bilateral disc edema. You can see swelling of the optic nerves. Visual field testing showed severe constriction. Everything that you see outlined in black is an area of her visual field that she could not see. So this patient was treated with systemic corticosteroids. However, there was no improvement in her best corrected visual acuity. Immunotherapy was stopped because the patient also had pleuritis and pleural effusion. She had progression of disease and is now deceased. This is another case of a 54-year-old man with a history of metastatic cutaneous melanoma who received 1 cycle of combination therapy and complained of progressive visual loss. Here you can see pockets of subretinal fluid, and you see yellow material. It's forming a little bit of a meniscus. We call this vitelliform material. So this is, you see one central large pocket of fluid and multiple satellite pockets of fluid. This patient was diagnosed with acute exudative polymorphous vitelliform maculopathy. And the subretinal fluid was confirmed on optical coherence tomography. This is a report of a patient very similar to the one I just described, but the patient developed acute exudative polymorphous vitelliform maculopathy after vemurafenib and pembrolizumab with similar clinical features, however, not as dramatic as our patient. A 79-year-old woman with metastatic cutaneous melanoma complained of photopsia, or seeing flashes of light, just after 1 cycle of ipilimumab and nivolumab. Her fundoscopic examination was completely normal. There was no deviation from baseline, no evidence of choroiditis, no subretinal fluid, no evidence of uveitis. So she went on to receive another cycle of combination therapy. Then she developed transaminitis, hypophysitis, and dermatitis, as well as worsening of her ophthalmic symptoms, worsening photopsia, and she had difficulty seeing at night, nyctalopia. Because of her transaminitis and hypopituitarism, she was treated with intravenous solumedrol without resolution of her ophthalmic symptoms. At this point, melanoma-associated retinopathy was high on the differential. So an electroretinogram was performed. And if you look to the left, you can see what a normal eye will look like. The B wave has that very high amplitude indicated by the arrow. But in our patient's right and left eye, she had a severely attenuated B wave, which shows loss of bipolar cell function. Anti-retinal antibodies were also obtained and were positive in our patient, and she was diagnosed with melanoma-associated retinopathy. So how do we treat these conditions? If mild, and if uveitis is just anterior, we can treat these patients with topical prednisolone. In more advanced cases, we can administer steroids via injection, periocular injections or intravitreal injections. And toward the right, you can see a depot. The white material is Kenalog, and there's a depot in his superior temporal fornix here. Sometimes patients are managed with prednisone. Other times, patients have to undergo treatment with corticosteroids or immunoglobulins, and rarely do we use plasmapheresis. In summary, immune checkpoint inhibitors are powerful agents which allow cytotoxic T cells to remain active and attack cancer cells. The ophthalmic immune-related adverse events are real. The incidence is about 1% and can occur within weeks to months of therapy and can affect various parts of the eye and orbit. Patients can have dry eye, conjunctivitis, keratitis, uveitis, serous retinal detachments, optic neuritis, autoimmune retinopathy, choroiditis, and myasthenia gravis, and myositis. So when these patients have dry eye, these can be managed with topical lubrication. Patients can present with conjunctivitis, where you see redness of the conjunctiva. And these are mild symptoms and can be managed with eye drops. However, keratitis can be more visually debilitating and cause blurry vision. We actually had a patient who had a corneal perforation where the cornea actually opened and the intraocular contents can then be extruded if the keratitis is severe. Uveitis, we talked about posterior synechiae, we talked about anterior chamber cell. Serous retinal detachments, where there's fluid underneath the retina. We talked about optic neuritis or optic disc edema and severe loss of visual field function. Autoimmune retinopathy, again, these patients can have a normal eye exam, normal fundoscopic findings. ERG or electroretinogram will show an attenuated B wave, which signifies loss of bipolar cells. And we discussed choroiditis, where remember the choroid is part of the uvea, so this is a type of posterior uveitis. Our patient who had a uveal melanoma developed myasthenia gravis after just one cycle of combination therapy. And she presented with left upper eyelid ptosis and double vision. And here's an example of what myositis looks like of the extraocular muscles. You see the medial rectus enlarged in axial and coronal views. And patients can present with cranial nerve palsies as well. Thank you. Any questions?
Yeah, we have time for questions.
So I have a question a little bit different. I noticed that one of the patients received for ocular melanoma. How often do you use immune checkpoint therapy for ocular melanoma? What are the results, particularly with respect or comparison to cutaneous melanoma?
Right, that's a great question. The question was, how does the use of immune checkpoint inhibitors differ for uveal melanoma when compared to cutaneous melanoma? Unfortunately, when uveal melanoma metastasizes, there's no great treatment. So we employ the use of immune checkpoint inhibitors. However, about 10 to 15% of patients will respond. Does not have the great overall survival that cutaneous melanoma has. And in that patient, she actually still had progression of disease. She only received one cycle of a combination therapy, but she had to undergo radioembolization.
Do you have more questions? I have a question. So do you see a correlation between the types of symptoms you see in the eyes and their systemic side effects?
In our study, we did not see that. Now, some people hypothesize that if patients develop immune-related adverse events, that these patients are more likely to respond to immunotherapy and more likely to have an improvement in overall survival. But when looking at the ophthalmic immune-related adverse event, there was no correlation.
I was just wondering about the etiology of the optic neuritis. You don't biopsy anything there, so you're just seeing the papilledema or the disc edema, right? So do you know what's going on? Are T cells infiltrating the optic nerve? Is it antibody mediated, or nobody knows? Or how do you know it's immune related is I guess what I'm asking.
Right. Well, we have to put the whole picture together in the setting of using immune checkpoint inhibitors. And again, these patients, when they present with ophthalmic immune-related adverse events, they also have other types of inflammation in the rest of the body. So we assume that this is all related to immunotherapy, but no one is. So in that case, she did receive corticosteroids. However, there was no improvement in vision. And in that was a severe case. She had a severe constriction in her visual fields. So it's very difficult to have that normalize. Yeah.
Do you have any additional questions? Oh, yeah, in the middle. I'm not sure I can make it there.
How long does it take diagnosis and the ophthalmic symptoms? How many months? Or does it vary per person?
So the question was, how long does it take between the diagnosis of melanoma and the actual symptoms? So what we looked at was not necessarily the time of diagnosis of melanoma, but more when immune checkpoint inhibitors were started. And from the time when the immune checkpoint inhibitors are started to the time of ophthalmic immune-related adverse events, it varies from weeks to several months.
More questions? No. Okay.
Okay, thank
so
you very much.
Dr. Lim. Great talk.